Hello, I'm Matthew Weinstock with Hospitals and Health Networks and continuing coverage of the American Hospital Association Health Forum Rural Leadership Conference. I'm joined right now by John Supplitt, the head of the small and rural constituency at the AHA. John, thanks for being with me today.
Oh, Matt, my pleasure. Thanks for having me.
So, John, I want to start. There's been a lot of reports in the media, but also data coming from the University of North Carolina on the number of rural hospitals that have closed. I think about 26 they report since May of 2010.
Right.
How concerned should we be about that?
I think we have to be concerned about it. We have to stay focused on these issues. As you pointed out, it's 26 over the period of time from May of 2010 to January of 15. And that's a number that you have to focus down on. You have to take a look at the reasons why they closed. You have to look at how they're being repurposed after they're being closed. University of North Carolina defines closure as no longer accepting inpatients, so I think that's a definition that we would share. And what our concern is that care will be available to those communities after these hospitals stop accepting inpatients, whether it's through emergency rooms, primary care, that there's some sort of a robust EMS service in the community. That's where we're focusing our concern.
What can we attempt to assess that's behind the closures?
It could be anything, and when you look at the studies by the University of North Carolina, they'll identify market factors, hospital factors, and financial factors, and any of combinations that can take place. And you have to look at each closure, individually, and drill down as to what the cause of that closure was. And for that reason, too, you have to look at what sort of mergers or acquisitions might take place in order to revive those hospitals or bring them back to an inpatient setting.
And obviously, one of the things that's always top of mind here is sort of the future state of the critical access hospital. How concerned should we be about those facilities?
I don't think you can generalize about critical access hospitals. I mean, there's 1,300 plus of them, and they all function in very different ways. Everything from the frontier critical access hospital that might only have an ADC of 2, all the way to those that have very robust surgical programs with subspecialties in the hospital themselves. So there's a very different sort of care delivery pattern that you'll see in them. I think what we need to do is first focus on the frontier critical access hospitals, because if you have a low average daily census and you're working in an environment where we're moving from volume to value, you've got to be able to demonstrate what it is that you bring in terms of value and can work within value-based purchasing. You can work within a risk environment that's going to be more along the lines of accountable care, and how can you function in that way? And there's been some government programs that have been out there to address the delivery of care in rural communities, like the Frontier Extended Stay Care Program and the Frontier Community Health Initiative, both of which have tried to address that and have to some degree. But we have to look at other models and other ways in which we can deliver care to the frontier communities and to other rural hospitals, whether it's critical access or small PPS, who are trying to bring care and have to look at their models of delivery.
And I guess keeping on a little bit of that theme, one of the things that's going to be talked about here quite a bit is sort of how rurals are evolving to new models of care. Tell me a little bit about what you're seeing from the AHA members that you oversee in terms of moving towards ACO models.
Yeah, we have some great case examples, and I want to compliment you and the Health Forum for both the trustee January issue and the Hospital and Health Networks January issue, which are packed with case examples of how hospitals have evolved and transformed as part of the health reform that's taking place in the communities. One that comes to mind is the regional provider network in Nebraska, where there are 9 hospitals, 3 metros and 6 rural, that have combined to integrate and begin to clinically integrate and share services across these hospitals while recruiting another 42 critical access hospitals across the state. They have maintained the independence of their ownership. In that sense, they've maintained their community identities. And I think what they're also striving to do is position themselves in the future so that when accountable care comes to these markets, they'll be the first to be able to respond to value-based purchasing. So that's a great example. And then on the other side of that, there's a 14-bed critical access hospital in Cochise County here in Arizona. It's the Copper Queen Community Hospital. And they've clinically integrated in probably one of the most innovative ways by telemedicine. They probably have up to 8 separate programs of telemedicine through separate hospitals in the area. Burn units, pulmonology, pediatrics, medicine, other services that they've been able to integrate clinically so that they can bring specialty care to this community that's on the border of Mexico, serving 2,500 square miles that they wouldn't have otherwise. So everything from the 14-bed critical access hospital to the larger PPS rural hospitals have found a way to transform their service delivery so that it's in line with the future of health reform, which really is value-based purchasing.
Right, and we'll be hearing a lot more about that here at the conference, or at least a handful of sessions that kind of focus on what hospitals are doing. Last question, Tom, taking a shift towards the policy front.
Yeah.
With a new Congress coming in, the president's budget being submitted last week, what would you say are the top couple concerns for the AHA from a rural hospital's perspective?
Well, as you know, the business of the 114th Congress for us is really the unfinished business from the 113th. But we're very excited in that 5 separate bills have come forward in this Congress already that is addressing the unfinished business of last Congress. The Critical Access Hospital Relief Act, which addresses the physician certification of the 96 hours, the Protecting Access to Rural Therapy Services Act, which addresses the general supervision and trying to eliminate direct supervision and set a standard for general supervision is out there. There's the bill that will extend the Medicare Dependent Hospital program as well as the low volume adjustment. There's the Flex IT Act, which I think is very helpful for rural hospitals because it does narrow the time that you have to spend in terms of testing your programs to test a meaningful use to 90 days, which is huge. And there's also the ambulance add-on payment, which has also been introduced in the Congress this week alone, so that rural providers or ambulance services that origins are rural will get the add-on payment for that. So just in this last couple of weeks alone, we've made tremendous progress in terms of the advocacy agenda for rural. And in terms of what do we need to be concerned about, we need to stay focused on maintaining the 340B program so that it's accessible to those that qualify, that are eligible, including critical access and sole community. And we need to focus on the fragile state of critical access hospitals, who really, once again, are being scrutinized by the president's budget and by others in terms of the reports that are coming from the OIG and from rules that are coming out of CMS. So those are the areas that we're going to be focusing on. But we have a lot to celebrate so far this early in Congress.
Well, John, I appreciate you taking some time to talk to me today.
My pleasure. Thanks for having me, Matt.
And we'll have ongoing coverage from the Rural Healthcare Leadership Conference, so be sure to look for that in H&HN Daily. I'm Matthew Weinstock. Thanks for tuning in.